Good evening, everyone. We're so excited to have those of you who've been with us before and anyone who this is your first time. We're just so grateful that you've decided to join us this evening. My name's Julie Evans, and I'm the Executive Director with Roots and Roads Community Hospice Foundation. This is, I believe, our third year of doing a virtual education series. The theme this year is Bridging the Divide. And as always, we have a lot of creative content, sort of emerging fields, some fun game nights, poignant stories, a whole mix of different ways that people have come to reflect on end of life. And so we're very honored to bring their stories to you tonight with Mary and Tom of Arizona End of Life Options. Before we get to them, I just want to tell you a little bit about Roots and Roads. Our vision is to transform the end of life experience into the final act of living well. And of course, that means something different for everybody, but a couple of ways that we go about that is by providing financial assistance to hospice patients and their families of limited means to help meet basic needs while they're going through end of life. Also, the reason we're here tonight is end of life education. And again, we go about that a lot of different ways, sometimes reviewing or viewing documentaries, having discussions with leaders in the field, game nights, etc. So we'll talk more about what's coming up this spring. And then our newest endeavor to support the community around end of life is a project, an online resource we're calling the Crosswalk, which if you haven't heard about it, we'll talk a bit more later, but here we are, we'll talk about it now. Thank you, Jennifer. It basically is an online resource to help walk folks from time of diagnosis all the way through end of life and beyond for those loved ones who are grieving, trying to make final arrangements, etc. And so Jen just dropped the URL into the chat there. We would love for you to just navigate around the crosswalk and give us any feedback you have. I mean, it's sort of it's beyond beta testing now, but literally we just launched it not 2 months ago tomorrow. So it's going to be a work in progress, and we welcome any ideas, any thoughts that you have to make it as inclusive, holistic, and robust as possible. Next slide, Jen. Oh, and this is where I turn it over to our amazing colleague, David Fife, Director of Community Engagement. David?
Thanks so much, Julie. Welcome, everybody. I'm so glad that we can start off 2023 again this year with this session, Dying in America. Care options near end of life. It's going to be it is a discussion that many folks in the community have asked for, and so I'm looking forward to see what Dr. Fitch and Mary Ganapul offer in their presentation tonight and where the discussion leads. I'd like to encourage you all, and Jennifer's going to drop a link in the chat box as well, if the way that we're able to provide these educational opportunities and the way that we're able to support hospice patients and their loved ones when they need support most is by the generous donations of people in the community. And so if you are able to and feel so moved, please take the time to make a donation to Roots and Roads. It will go directly to supporting this mission and work in our community. So thank you so much. And now we want to warmly welcome Dr. Fitch and Mary Ganapul with us tonight. You can see in their bios a bit of their history. Dr. Fitch has worked for decades here in Arizona at the Mayo Clinic in the fields of hematology and oncology, and also hospice and palliative medicine. He's served as Associate Professor of Medicine at the Mayo Clinic College of Medicine. And then in 2018, he was diagnosed with multiple myeloma and non-Hodgkin's lymphoma. And from his experience professionally and also the treatment and dealing with his own cancer diagnosis. He has worked and been involved in the Arizona End of Life Organization, a volunteer organization dedicated to passing a medical aid in dying law here in Arizona. And we are very grateful to have Dr. Fitch with us and the wealth of his experience and wisdom that he can bring to the discussion. Mary Ganipold is also with us. I've had the opportunity to work with and talk and collaborate with Mary for a number of ways. She's wonderful. She's been a resident of Tucson, Arizona since 1997 and was a contract investigator for federal agencies throughout Southern Arizona. And then she also owned a home care franchise in Green Valley called Seniors Helping Seniors. And since entering retirement, she has continued to advocate for seniors and serves on the boards of the League of Women Voters of Greater Tucson. That is a fantastic. Thank you so much for doing that, Mary. And the Secular Coalition of Arizona. She is the Southern Arizona lead for Arizona End of Life Options. And so thank you so much to both you for being here. We're going to begin by having Dr. Fitch begin with a presentation, and then there will be a short question and answer time following Dr. Fitch's presentation. And then he will turn things over to Mary, who will also have a short presentation and followed by Q&A as well. So as Jennifer said, during the question and answer time, you will be able to unmute yourselves and ask the questions directly. If you would like to do that, that's a wonderful way to have this kind of dialogue. But if you don't feel comfortable doing that, or you'd prefer to just drop your questions into the chat, we'll be monitoring that. The chat box is at the bottom middle of your screen. And then we will get to as many questions as possible. So now we're going to turn things over to Dr. Fitch. Thank you again for being with us, and we're looking forward to this time.
I'll get my slides up. Good. Can you see that? David, can you see?
Yeah, it looks great. Thank you.
Good, good. Well, thank you, David. It's really an honor to be here. I'm getting to know Roots and Roads and very impressed with them as an organization. And I really honored and appreciate an opportunity to talk for them. As David mentioned, I have been, or was, I guess I still am, a hematologist and oncologist, but was with Mayo really starting back in 1985. I came to Mayo Clinic, Arizona from Rochester, Minnesota, and came down here in 1988. And my initial part of my career was medical oncology and hematology. But if you ask, how did I end up really primarily as a hospice and palliative care physician? And it was about my belief that end-of-life care could be better. Obviously, I cared for lots of patients with malignancy and helped them through the end of life and death. And my perspective was that we could do a whole lot better job. And it was about the same time as the hospice had begun, but the discipline of palliative care was beginning. And my interest in palliative care grew and grew. And towards the latter part of my career, I was doing really probably 90+% hospice and palliative care. And then, as David mentioned, I was diagnosed myself in the summer of 2018 to have multiple myeloma and lymphoma. I've been through lots of treatment, including a bone marrow transplant, not been able to achieve remission, but good news is I'm doing pretty well with treatment, but obviously end-of-life care personally became an important part of my life. So that gives you at least a little perspective of my interests here. So I'm going to talk a lot about end-of-life care, and I'm going to start by talking about, again, those shortcomings in end-of-life care in this country, which unfortunately I think have certainly improved, but there's still significant room for improvement in this country and how we care for people at the end of life. And I'm going to talk about that and then talk about the end-of-life care options that people need to be aware of and too often are not. And then Mary is going to talk a lot about one of those end-of-life care options that we're both working through. End-of-life care options. It's a group of volunteers that I have periodically tried to help. And the goal of end-of-life options, Arizona end-of-life options, is to pass an 8 and 9 law in the state of Arizona. And Mary is going to talk a lot about that. But again, I'm going to talk about the shortcomings of end-of-life care and then talk about end-of-life care options. So if you ask people how they want to end their lives, nearly 90% of people will say that they, first of all, want to die at home with their loved ones. They obviously also want to be as free as possible from pain and any other suffering that might exist. And they want their social, emotional, and spiritual needs addressed. And they want their own wishes, values, and well-being supported, not that of the medical community. And this is something we could talk about a lot. Each of these points we could talk all night about each. But there was a report called Dying in America that was published by the Institute of Medicine in 2014. It's hundreds of pages long, but there is an executive summary, and these are free. If you get online and Google Institute of Medicine and look at their reports, you can find the Dying in America report. And it talks a lot about, again, the shortcomings of dying in this country. And if you look at that report, and still today, there are key statistics. Unfortunately, the majority of us do not die at home. Although 90% of us would like to die at home, nearly 60% of people still die in a hospital or other medical facility. And if you look at decedents and what happens to them as they near death, ER visits and hospitalizations are frequent. 75% are seen in the emergency room in the last 6 months of life. 50% of decedents are seen in the emergency room in the last month of life. 75% of those that are seen in the emergency room are admitted to the hospital. 1 in 5 have major surgery in the last month of their life, and 1 in 5 in this country still die in a critical care unit. So this medicalization of dying in America, why does this continue to happen? And I'm going to go through each of these points in a little more detail, but I wanted to outline the points I hope to make. First of all, there's a real mismatch between what is really needed by patients and family, those really the social determinants of health, and what is provided by the medical community, the government, and in our insurance policies. There's often poor communication between medical providers and patients and families that leads to poor informed consent. There's poor to no advanced care planning, and there's a poor understanding, and there are misperceptions regarding palliative care and hospice care. What are their differences? What do they provide? When should they be engaged? And there's no knowledge of the options of end-of-life care for many people as they near death. So this leads to what I call let's try this medicine and the tyranny of survival, and we'll talk about that a little bit more. So first, this mismatch between what is needed by patients and family and what is provided by the medical community. Uninsured rates in this country are better, but they're still 20% or higher, certainly higher in some populations, and amongst those who are economically poor. Affordable health care and caregiving is not available. It was always stunning to me that, well, understandable, but patients I saw leaving the hospital or leaving the hospice unit and families were stunned and distressed to learn that health care at home was not provided. And they worried who was going to be the caregiver if somebody's dismissed from the hospital. They had to work, and if they didn't work, they lost income and they lost their jobs often. Long-term care is unaffordable for most. And if you really look at long-term care policies, they're really poor. They often, if you try to initiate a long-term care policy, there's often a 6-month delay until the request and then until at the point it's initiated. Unfortunately, our jails and prisons with the high incarceration rates in this country have become our largest psychiatric facilities. And as we all know, there are increasing rates of what are called diseases of despair. Mental health issues are rising, addiction is rising, and suicide is rising, particularly amongst the young. There's little and those diseases of despair are particularly prominent in relatively young white men with limited education. There's been little investment in behavioral health despite the rapid increase in chronic diseases. We are living longer, but as we live longer, we tend to develop disease, and behavioral health is not available for most patients. So regarding what actually has the greatest impact on our health and outcomes, the US healthcare system really has missed the boat. If you look at what are called the social determinants of health, interesting, if you look at the impact of medical care, all the money we spend, literally the trillions of dollars we spend on medical care in this country and what determines health, medical care that is provided impacts only 10% of our overall health. Patient choices, again, patient choices, again, where behavioral health could have a huge impact. Things like diabetes and hypertension, those kinds of diseases, their behavioral health can have an enormous benefit for patients in helping them understand their diseases and their lifestyle choices that have an impact. Social impact, things like, are they employed? Do they have a way to get back and forth to their medical appointments, to their jobs? Do they have sufficient food? Those sorts of things obviously have an enormous impact on health. I'll never forget a talk I heard about an expert on the social determinants of health, and talked about people with diabetes and coming in to get at a free clinic, getting the best of wound care at the clinic. But unfortunately, when they left, that didn't help much when they didn't have shoes. So again, these sorts of things can have an enormous impact on people's health, but there's little investment in this country. The investment is directed toward medical care. There's a lack of complex communication skills amongst providers. They're not taught, still often not taught, even in medical school today, and not during residencies and fellowship, and they're often never learned. As I became a palliative care physician, I ended up having the opportunity of being in a room with many of my hematology oncology colleagues, who often were friends, and I could witness, not that I have the best communication skills in the world, but I did work hard at that. And it wasn't that my colleagues didn't love their patients, but they just didn't have the skill to talk about patients who weren't doing well and why they weren't doing well, and to talk about the possibility of dying and death. And it wasn't discussed because they couldn't bring it up. They didn't know how to talk about it. So that ended up into, let's try, the easier conversation was trying the next medication. So this was, as I mentioned, especially true when the topic was dying and death. And far too often this led to no true meaningful consent. Patients, if patients understood, the example I bring up a lot of people with advanced pancreatic cancer, where there are limited beneficial therapy. Things have improved a little, but if you see people with metastatic pancreas cancer, you find out that they're on third or fourth line therapies. And if they knew that the chance of benefit from third or fourth line treatments were closer to zero than any other number, if they really understood that, and they understood the potential risk and shortcomings of the treatments they were taking, they would make different choices. But those kinds of conversations just didn't happen. I always like this cartoon. Again, regarding dying and death conversations, they didn't occur. And this is the elephant on the psychiatrist's couch. And he says, sometimes even if I stand in the middle of the room, no one acknowledges me. And that's I think, true about dying and death in the medical community. So poor communication leads to not only poor informed consent, but poor to no advanced care planning. Advanced care planning includes a medical power of attorney, an advanced directive, termed a living will. Many states have what are called POLST orders, or physician orders for life-sustaining treatment, and pre-hospital medical directives. How does somebody want to be cared for if they call an ambulance? In Arizona, that's called the Orange Form. I did a study when I was the chair of our palliative medicine group in Arizona, and I reviewed all consultation requests because I was looking at those consultations and why palliative medicine was being asked to see patients. And I kept track of all the consultation requests that came from my division of hematology oncology. In over a year, we had hundreds of consultations, and these were patients with advanced cancers who were being sent to palliative care, often late in their course. And less than 30% of those patients who had been cared for in the division of hematology oncology and other divisions at Mayo, less than 30% had completed advanced care documents. So these are important, and most important, naming a medical power of attorney, someone who knows your wishes if you were to lose the ability to personally express your wishes. That's very important. And somebody who knows not just your wishes, but your values and what's important for you in life, and to be able to communicate that to your medical providers. I used to tell people to do a personal letter about what's important in your life, what makes you who you are, and what your choices would be if you reach a point where you're really no longer you. And to put that into a letter and then read that letter. Obviously, there's access to video. Use your phones and have one of your loved ones record yourself reading that letter. There's nothing more powerful than to be able to give something like that to your medical team. Then there's a very poor understanding, and there's misperceptions regarding palliative care and hospice care. We need to inform the public and medical providers and educate them regarding the role and benefits of palliative care and hospice care for patients, particularly patients who have advancing life-limiting illness. And I'll go into that a little bit more in just a second. Patients and families should be encouraged to seek providers with expertise in end-of-life care. They should ask for consultations with a palliative care team. And Mary knows a lot about this, but advocates who are certified in end-of-life care and end-of-life care doulas. And then at appropriate time, and again, I'll talk about this a little bit more, to get hospice care involved. Again, too often, even though my colleagues in I feel like I'm beating them up a little bit tonight, but as I became predominantly a palliative care physician, who were close friends, my colleagues in hematology and oncology were still reluctant to consult palliative care, no matter how many times I talked to them about the benefits of getting us involved. I always like this quote from Woody Allen, because I think this is true for many people who have advancing serious illness and who understand that they're slowly declining and death is not too far in the future. And Woody Allen's quote was, "I'm not afraid to die. I just don't want to be there when it happens." And if not most of the people I cared for, that death itself was not what they feared. It was the process of dying. Again, the worries about pain and other forms of suffering, and their spiritual distress, mental health issues, all those things that affect people, worries about their family and being a burden to others. Again, we need to address those sorts of things. And those are the things that people with advancing serious illness worry about. So this was one of the summary statements from the executive summary of the Dying in America study done by the Institute of Medicine. Their statement was the overall quality of communication between clinicians and patients with advanced illness is poor, particularly with respect to discussing prognosis, dealing with emotional and spiritual concerns, and finding the right balance between hoping for the best and preparing for the worst. Ample evidence documents structural and financial disincentives for having these discussions. In the absence of adequate documented advanced care planning, the default decision is to treat a disease or condition, no matter how hopeless or painful. And that's what I called, again, let's try this medicine. That's an easier discussion to bring up another treatment, no matter how hopeless that treatment might be. And that's too often what happens. So I mentioned what is called the tyranny of survival. And this is from Alan Verhey in a book he published in 2011 called The Christian Art of Dying. And in that book, Alan coined this term, the tyranny of survival. And he described this as in the endless efforts to defy death via more and more treatment, the opposite occurs. Relentless disease-directed treatments lead to as much and often more pain and suffering than the disease itself, and commonly a shortened survival. Death is allowed an early victory. And I bring up, how do you really define do no harm? And as I mentioned, that if people really receive good, compassionate, but real informed consent about the treatment options that are being discussed, their limitations, the risks, and the risks that the treatments actually might shorten somebody's life. Again, patients and families, I think, would make different decisions if they receive that kind of informed consent. And this is from me, that we must acknowledge our shortcomings as we care for people with advancing very serious illness. We must begin to focus on the morality and ethics of the care we provide for people while they die, especially our advocacy for endless, relentless disease-directed therapies. We too often push treatment after treatment despite the lack of home health and affordable caregiving, the paucity of meaningful mental and behavioral health, the impotence of the informed consent which is provided, the absence of advanced care planning conversations, and clear documentation of people's values and goals, and our reluctance to refer patients to palliative care and hospice care. I really think this is simply unacceptable and often morally bankrupt. So if we begin to kind of shift from the problems, and I don't mean to beat up medicine because there's lots of remarkable medicine happening in this country, but again, end-of-life care can certainly improve. And as the statement from Dying in America study, it all really does start with communication. We need to improve the communication skills of all medical providers. And healers really should be able to enable the well-being of their patients. That should be our goal. Enable that which defines who they are as a person and what makes their life worth living. We should do that by tailoring the medical care of our patients in a manner consistent with their wishes, goals, and values. Now, you can't tailor their medical care without really knowing what their wishes, goals, and values are. You have to talk to them. So as their illness progresses, we should ask them such things as, what do you value most in life? What are your goals? Knowing the likely course of your illness, you got to have that discussion too. What is the likely course of their illness? And what is their prognosis? What are your most important goals? Knowing the course of your illness and your prognosis. How do you want to be cared for at a point where you can no longer pursue the things that give meaning to your life? And also ask, how do you want to be cared for if you reach a point where you are no longer you? That's where those POST orders, physician orders for life-sustaining treatments, What kind of advanced care do you want or don't want? I told people if you talk about advanced care planning documents, people are fearful of them because they think they're going to say something and it's not reversible. It's written in stone. And, it's hard to get them to begin to think about that, but I reassured them that number one, advanced care planning documents are only come into play if the patient loses their ability to provide their own wishes. They are no longer competent. And they are changeable and they should be addressed and readdressed. And I would often tell them at this point in your illness, you might want all available care, and we should put that down. If that's your wish at this point. Again, as your illness changes, we'll readdress this, and your wishes might change. And again, I did ask them to write that letter about what was important in their life and do that recording. So to document in the medical record, ensure the patient completes advanced directives. Perhaps we best do no harm by not subjecting our patients and their families to the tyranny of survival. And in kind ways, you have to talk about what is the tyranny of survival in illnesses. And there's a lot of that in cancer care, unfortunately. And again, perhaps we best do no harm by not overriding our patients' well-informed and ethically sensible belief of how they want their lives to end with dignity. Oops. So if we look at end-of-life care options, it's kind of a busy slide. All my slides have been a bit busy. But in red, you see in the middle about stopping disease-directed therapies. There comes a point in all illnesses where continuing treatment after treatment after treatment does lead to that tyranny of survival. There comes a point in all diseases that stopping more and more disease-directed therapies, people will do better and live longer if those kinds of endless treatments are stopped. Now, I don't want to pretend this is an easy decision point. It's probably the most difficult decision point in all people's illness and their treatments, but that has to be discussed and considered. Now, some people will choose to go on with treatment after treatment, that's part of their makeup. That's what they need to do. There's an article that I read long ago about a physician who wrote about his mother who had what is called myelodysplastic, kind of a pre-leukemic bone marrow syndrome, very difficult to treat, particularly in older folks. And his mom was older, but she pursued treatment after treatment after treatment. And all along, her physician son had talked to her about stopping treatments, and she never did. And as she was dying, her son, said to her, I'm sorry, Mom, we didn't really have to put you through all of those treatments. And her response to her son was, I do it all over again. And if that's after a true compassionate but well-informed consent, if patients make those choices, that's okay. As long as you know as a physician that what you're providing as treatment has at least some chance of benefit. And so I don't advocate for useless treatments, obviously. But getting back to the point that there comes this point of stopping disease-directed therapies. But in somebody with an advancing serious illness, getting palliative care involved early. There was a study done at Harvard, good institution, of people with new diagnoses of advanced lung cancer. And the study was half got palliative care, half did not. And they got it at the time of diagnosis. Palliative care is a group, a multidisciplinary group of providers, including physicians, nurses, social workers, chaplains, pharmacists, again, a multi-specialty team, or what we call multidisciplinary team, that has expertise in symptom management, communication, informed consent, provides family support, social support, emotional and spiritual support, and advanced care planning. All of those things that are important as part of serious caring for people with serious illness, and so often again get overlooked. That's what palliative care is all about. It's that extra layer of support given in conjunction with cancer doctors, heart doctors, lung doctors. It's not giving up in any sense of the word. It's providing all that extra support that makes such a huge difference. So getting back to that Harvard study, the patients in the study got palliative care or got palliative care only if the oncologist requested a palliative care consultation. That arm of the study, and you might believe, less than 20% ever got palliative care and their oncologist ever consulted palliative care. The other arm of the study got all of this other support that palliative care provides. And as you might imagine, they did better. They had better symptom support, less depression, less pain. They were in the hospital for shorter periods of time. There were less hospitalizations, less admissions to critical care units, earlier enrollment in hospice, more involvement with hospice and earlier enrollment in hospice, longer length of stays on hospice, less chemotherapy towards the end of life. What a lot of people would say were less aggressive treatments. But when you looked at length of life in those two groups, the people who received early palliative care did better and actually lived longer. So there are enormous benefits of getting palliative care involved early in people with advancing serious illness. Again, before stopping disease-directed therapies, in fact, given along with disease-directed therapy. But at a point where you make a decision that more and more treatment is not in that patient's best interest, evolution to hospice care is very, very important. Hospice care is palliative care, same kind of support, but its involvement is at a point where patients have decided not to pursue further disease-directed care. And in this country, Medicare pays for hospice when there's a prognosis of 6 months or less. Now, if you make a mistake, patients live longer than that. They're very good about re-enrolling people in hospice care. Then as death becomes more imminent and patient suffering increases, other things need to be addressed, other options of end-of-life care, again, as death is coming closer. Discussing with patients about withholding or withdrawing advanced supportive therapies and/or devices. People think a lot about breathing machines, being in a critical care unit and withdrawing people from ventilators, and that's a discussion too, as is people who are on dialysis about whether or not they want to continue dialysis. But other things too can be discussed. Do they want to be hospitalized or not? Do they want to be taken to the emergency room or not? If they have cardiac support devices, a defibrillator or a pacemaker, do they want to have those removed or stopped? Do they want antibiotic treatment if they develop a serious infection? All of those, they may want all of those things, but at least they should be discussed and discussed what their wishes are in each of those settings. There is the option of what is called voluntarily stopping eating and drinking, or VSED. That's where a patient who's near the end of life, that if you truly stop eating and drinking, death is going to come sooner, generally within 7, 10, 12 days. It's a difficult thing to be done, but it's legal in all states. Patients have the ability to refuse or to stop any treatment they want, and eating and drinking within the medical field is considered medical therapy. So a patient can do that. They need the support of their family and they need the support of their hospice team. There is such a thing called palliative sedation, which is available for patients. It too is legal in all states in this country. Palliative sedation is giving sedation to people with the intent of treating intractable suffering. The purpose is treating intractable suffering. Can be intractable pain, for example. I had a patient in her 40s with advanced pancreatic cancer, and I had cared for her as an oncologist. And she had intractable pain. We had her in a hospice unit for several weeks and could not control her pain. I walked into her room one day and she literally got down on her knees asking for help. We talked to her family, her mother and father, her husband. She had a 10-year-old son who was one of the most mature 10-year-olds I'd ever met. We talked about the possibility of palliative sedation. She requested that after discussion. Her family was supportive, so we started sedation. We had to sedate her to the point of unconsciousness. Now, in that setting, you don't provide hydration and they don't eat. And she died about 10 days later, but that's what palliative sedation is about. And then there's medical aid in dying, and Mary's going to talk a lot about that with you. So I think, too, the most important thing for you, if you're involved with people as they near end of life, is to be present. This is a picture from the National Memorial for Peace and Justice. I don't know if you know the name Brian Stevenson, who wrote the book Just Mercy. He was also the primary proponent of building the Memorial for Peace and Justice. And this memorial is about the lynchings that occurred during and after Reconstruction, and unfortunately through the early 1950s. It's quite a memorial, and this is a person who's present. And Brian Stevenson tells a story in his book, Just Mercy, which is about incarceration and his defending people who were given the death penalty, many of them innocent, and in particular one patient who was clearly innocent, and how difficult it was to get his sentence reversed. But there was a gathering in the courthouse, and to get into the courthouse, you had to go through things to detect guns. Forgotten the name of that, but also this large dog. Long story about a beautiful Black older woman who it took everything she had to. She was one of the people chosen to be able to go into the courtroom to support this man. And she finally was able to get through all of that. And she walked into the courtroom. The judge came in, everybody stood up, and she remained standing. And the judge asked her, and she just kept saying, "I am here. I am here." It was important for them to know that she was here to be present for Mr. McMillan. And I think that's a story that, again, to be present for patients as they near end of life is probably the most important thing you can do for them. So I'll stop there. Thank you very much. And I'll stop the sharing, and I can take questions. If we would like to do that now, I can take questions.
That would be great. If anyone has a question, you're welcome to unmute yourself and just go ahead and speak. Also, just to remind you, you can type questions into the chat box as well.
Quietness.
I have a question.
Ask,
Wondering if HIPAA regulations have affected the care of people at the end of their life.
Oh, I don't think to a large, I mean, HIPAA has affected everybody's care across the entire spectrum of care, but I don't think it interferes with good end of life care, really. You know, that I think people who still have capacity are able to speak for themselves. You can always ask them, you know, who can I talk to or not talk to? I think it is important, though, that you realize that you have to adhere to HIPAA regulations. I'll never forget when I was a young oncologist taking care of a woman with cancer, and her daughter called, and I just spoke to her, told her daughter, and I didn't think, I had not spoken to the mom about whether I could speak to the daughter at all. And I told the mom that I'd spoken to her daughter, and she got very angry at me. And she said, I never gave you permission to talk to my daughter. And so I learned a lesson very early on in my career. So it's very important to adhere to HIPAA, but I think if you keep the patient first in your mind, that you can get past those rules without too much difficulty.
Lavina, did you have a question?
I think Elsa had a question first.
Oh, well, thank you. I was just wondering if there were sometimes patients who just could not have the discussion about end of life, or is that quite rare?
I think it is. I guess I would call it rare, but it's not as if that never happens. A lot of times, particularly in different cultures, many cultures are such that contrary to kind of the independence and autonomy in the U.S. culture, other cultures are more family directed. That I think you have to give the patient the right of first denial. But sometimes I will, if you really ran into somebody who you would ask were they ready to talk about some difficult things about their illness and what was happening and their prognosis, and they said, no, I don't really want to talk about that, then I would ask you, is it okay if I talk to your husband or your children, or is there somebody in your family who you'd like me to talk to them about that? And many cultures, that is the culture, that that you don't talk to the person who's ill, you talk to the family members who then kind of talk to them. Again, I think you have to give them the right of first refusal. But I think when you do run into patients who would rather not talk about it, I think then I would ask about, again, talking to a loved one of theirs or family. And I would keep coming back to them and very gently saying, do you have any questions about what's going on? Those kind of open-ended kinds of questions.
Thank you, and thank you for all you've shared with us just now. Really very, very important.
You're welcome.
I was going to say the same thing, Dr. Fitch. Thank you for being so direct and clear-minded about some of the downfalls of our medical system when it comes to end of life. And I'm curious to know how your colleagues in the medical field have responded to you and your opinions and your values.
Yeah, I think the good news is, although to be honest, we have a ways to go, but the whole, the hospice movement has been going on in this country since the late 60s, early 70s, and palliative care more recently kind of in the 80s to 90s. But those movements, and particularly, well, I think both of them, but palliative care has been later, and palliative care more directly involved in hospital care, for example, and there's an increasing world of outpatient palliative care. So I think those movements are making inroads. I know, for example, in Mayo, there's a whole movement about education regarding communication skills, advanced communication skills, and that's and there's within the palliative medicine world, there are courses now in communication skills, and so and Harvard, for example, has developed a serious conversation course. So we're making inroads and I think, beginning to make a difference. People are kind of beginning to understand that palliative care is not about, they too often in the past have equated palliative care with hospice care, meaning we're going to stop all other kinds of treatment. And that's not what happens with palliative care.
Thank you.
So I'm hopeful.
Good.
There's a question in the chat that says, I have been concerned about the quality of hospice and those companies that seem to be in the business for dollars rather than compassion. Any thoughts about this, as it seems to be a growing business? And I think it might be reflective. I don't know if you read, Dr. Fitch, the ProMedica and New York Times piece. I think they titled it "The Hospice Hustle," about prioritizing profits over patient care. And I don't know if you have any things to respond to that question.
Yeah, well, I suspect there's a number of people here, including yourself, David, who can talk to this, and Mary certainly can too. I don't think we can deny that this exists. I think there are for-profit hospices, unfortunately, who, profit becomes their bottom line, and they sometimes compromise care. Now, obviously, that's not true of all for-profit hospices at all. So I think, I always tell people, talk to nurses, talk to hospice nurses. They're the ones who will tell you the truth. And I try to do, it may be my bias, but I direct people towards not-for-profit hospices. That I think, again, just knowing that this can exist, and if you're looking for a hospice, not-for-profit hospices, and again, to talk about people involved with different hospices, particularly their social workers and nurses, I think will give you good insight into that hospice.
Thank you so much. And I just was so impressed with your presentation, Dr. Fitch, and all of the different elements you brought into this discussion. But I also want to lift up, and Julie dropped it into the chat as well, is that the crosswalk that Julie talked about earlier really tries to define all those things that you were saying were so important about the differences between palliative care and hospice, and who the agencies are that are providing that care. And really the idea is to empower our community with the information, the tools necessary to make the best informed decisions possible for themselves based on their own values and goals. And so I encourage you to look at that and see what might be helpful with it, but that is part of the conversation that we need to be having when it comes to palliative and hospice care. And somebody asked, how does one find palliative care in Tucson? And so there's palliative care, you say, Dr. Fitch, in terms of the acute care centers, but home-based, community-based palliative care, if you all would like, you can go onto the crosswalk, and there's a listing of agencies who provide that here in town.
Yeah, thanks, David. I forgot. When I saw that, and that was mentioned about crosswalk, I think that's just a wonderful resource. Kudos to you and the Roots and Roads team to create that and provide that resource for people.
Thank you.
I have a question. I've been taking copious notes, but I'm also wondering, so I'm going to use a lot of these things that you're discussing, but I'm wondering, do you have other suggestions for when you're having conversations with your parents? Because every time I talk to my parents about this kind of stuff, they always say, oh, they push it off, or they'll say, well, what do you want? And I'll say, well, it's not about me.
I'm going to grab something real quickly.
Okay.
I think this is a wonderful, it's a game. You can't see it very well, but it's called My Gift of Grace. And you kind of sit around the dinner table and draw these cards, maybe have a little wine if you're wine inclined. And they're cards that kind of ask end of life questions. And, I think if you could get your parents to kind of participate, it's kind of a friendly, I think, gracious way to kind of bring up the topic of end-of-life care. And I particularly, I think the sooner the better. When people are well, it's I talk about, as I mentioned about advanced directives, is just to explain what advanced directives are really all about. They can always be readdressed and changed. In fact, they should be readdressed and changed. And so this is again, my gift of grace is a conversation game for living and dying well. It's just kind of a good way to introduce those kinds of.
Hold it up again. Can you just hold it up one more time? My gift of grace. Okay, thank you.
Yeah, I'll definitely get that. I did finally get out of my father that he would like to stay in their house for at least one more year. So I was like, okay, there's a starting point to,
Yeah.
getting somewhere with the two of them.
Yeah, driving and houses, those are always huge decisions. And
Right.
I kind of understand. The other thing, I think the resources in Crosswalk may be helpful, but certainly Compassion and Choices, a national group that's been around a long time. It's really a group whose primary goal is about aid in dying, but on the Compassion and Choices website, they have enormous amount of resources and things for people to read and things you can print off for free. And
Dr. Fish?
Yeah.
This is Alan Baruther, and we've talked before.
Yeah, hi, Alan.
And I'm glad we finally got you down to Tucson. And I just want to say I've been hanging around the hospice area for many years and reading a whole lot. And I can't believe the presentation you just gave. It was so succinct, but so encompassing. And I wish every practitioner out there could sit through just 40 minutes of your presentation. You put so much into that, not only what's in print, but from your experience, and it really made it very impactful for me. I wish everybody could hear your presentation that you just gave us tonight. It's amazing.
Well, thank you, Alan. You're certainly, it was recorded, I think, and you're certainly free to use it. I'm happy to my slide people. You can have my slides and whatever I can provide.
And I'm going to put another plug in for another card game, Go Wish.
Yeah.
And this one actually tries to get people to say what they want for themselves.
Mm-hmm.
And it's a game with things in life, you go through them, and you start limiting them near the end of the game, and you come up with the most important thing in your life at the time your life ends.
Yeah,
so this one's also got a website, and it's the Coda Alliance that puts this one out.
That's a nice one.
Thank you.
I believe that Dr. Fitch, that you're going to need to go. Is that correct? Kind of at time?
Yeah, I'm sorry. I was just looking at the chat room here real quick if I can. Oh, Mary had put in, it's also, it's easy to switch to another hospice company and things like that. That's good.
Yes. And we will put the recording of this session up on our website. Usually it takes us about a week or so to get that edited and up, but you'll have access to that, to the presentation, and see the slides again for everyone. But thank you so much, Dr. Fitch. This has been wonderful. It's really been fantastic, and we wish you many blessings.
Yeah, thank you, David, and thank you, everybody, and thank you for having me. You'll enjoy Mary's presentation too, I know.
Absolutely. Take care.
So I will. I guess I'm not sharing, so I can.
Okay.
All right. Bye-bye.
Bye now. So we are so honored to have Mary Ganapole take the baton now and lead us in further discussion. So Mary, take it away.
Thank you. That was so great to hear, Dr. Fitch. You know, I've heard that presentation a number of times, and yet I sometimes hear something new, which is really neat. My takeaway on this time that I heard it was that idea that the lack of communication between doctors and patients is actually interfering with informed consent. That's really an interesting concept, you know. because we talk about informed consent so much. And if people aren't really clear on what their choices are and what the percentages are for successful treatment, then that really is not exactly informed consent. So that was very interesting. I'll also give a plug for two other things, the Conversation Project and Death Over Dinner, which are two other really great ideas on how to get the conversation going about end of life options and advanced care planning. And they all recommend you have the discussion more than once, not just over dinner one time. So thank you for asking me to speak. I think it was good because I knew Dr. Fitch talks about medical aid in dying at the end of his talk as one of the options. Unfortunately, it's not available in Arizona, but it's also very misunderstood. So I'd like to clear up some misconceptions about it and explain exactly what medical aid in dying is. I'm also with Arizona End of Life Options, and I'll mention we have the support of two national groups, Death with Dignity and Compassionate Choices, which Tom had mentioned. So what I'm going to cover, and I'm going to go through this pretty quickly so that we do allow some time for Q&A. I'm going to clear up the definition of medical aid in dying, what it is and what it isn't, the qualifications and safeguards of the law where it's legal, and what's happening in Arizona. So as far as the terminology is concerned, the preferred terminology for this is medical aid in dying, often with the initials MAID, or Death with Dignity. And the terms physician-assisted suicide and physician-assisted death are really used by the opposition. So if you're reading an article and it's calling it physician-assisted suicide, it's probably an opposition article. We also don't call it euthanasia, and there's some confusion on that because it's used in Europe. They call it also euthanasia, but in the US, it's not called euthanasia. Euthanasia is illegal in all 50 states. It's unlike, the definition is really, euthanasia is when there's a third party involved, usually a doctor who gives a lethal injection. So that is unlikely to be considered in the future. It's not really something we do here in the States. It's not to be used interchangeably with medical aid in dying or death with dignity. In fact, there's a group that likes to have this button that says, "Let me die like a dog," which I think is very offensive because we euthanize our dogs, but we don't euthanize humans in the United States. And throughout this talk, I'm going to really focus on what we're doing here in the US. So what exactly is medical aid in dying? I'm going to break it down by these red highlighted segments. It's a medical practice in which a terminally ill, mentally capable adult with a prognosis of 6 months or less to live can obtain medication prescribed by their doctor to be self-administered to die peacefully if and when they choose. So it's a medical practice. I like to show this VW bus on the left-hand side. This was Dr. Kevorkian's bus. And not a presentation goes by without somebody mentioning Dr. Kevorkian, and it's really maddening because I think there was a lot of really bad medicine going on there, and I think he set back the right to die movement by a mile. And when they studied the 130 people that died under his idea, there was a lot of really questionable things going on. So this is a medical practice we're talking about, not something that happens in the back of a VW bus. It's for terminally ill people. 63% of the people that take advantage of a medical aid in dying law where they live have cancer. And then you can see the percentages for the other terminal illnesses. Mentally capable adult. So this rules out people with dementia. And I can get into that a little bit more at the end on what is available for people with dementia, but medical aid in dying is not available for people with dementia. It's only for adults, that's people over 18, the majority are over 65. If someone has questionable mental capacity, then a mental health evaluation is triggered. 6 month or less prognosis. So We talked a lot about hospice already. They had to have some sort of milestone when they designed this law, and they figured that the easiest thing would be this 6-month or less prognosis, because that's what we're used to for a hospice milestone here in the US. It's misunderstood. Some people say if we have hospice, we don't need medical aid in dying, or if we have palliative care, we don't need medical aid in dying. It's not one or the other. 90% of the people who use medical aid in dying are already enrolled in hospice. It's not a requirement for medical aid in dying, but they go hand in hand. It's in addition to hospice, it's another option that people have. So it's misunderstood that hospice can replace something like medical aid in dying. It's in conjunction with it. It's a medication prescribed by their doctor. This is a combination of various drugs from a compound pharmacy. It's a formula that's been fine-tuned over the years by this group in California, American Clinicians Academy for Medical Aid in Dying. They get data and information from all the doctors who are in the states where it's legal, and they have a formula of about 5 different drugs that are combined at a compound pharmacy. So it's not something you're going to be able to pick up at Walmart, Walgreens, or CVS, but it's through a compound pharmacy. To be self-administered. This is why it's not euthanasia. There's not a third party administering this medication. It has to be self-administered. This also proves that you're not getting help from somebody else and that there's no coercion in the picture. There's alternatives for people when they can't swallow, like for the Parkinson's or ALS. They might have rectal catheter or be able to put it into a feeding tube. And again, patients can change their mind at any time in the process, if and when they choose. So this is patient-driven and a patient right. Surprisingly, of course, people can go through all the steps to qualify for medical aid in dying and don't take the medications. And surprisingly, 30% of the people do not take the medication and die of their disease without doing medical aid in dying. It's kind of a large percentage, but it shows those people have it just in case in their mind, they would want to take it. Maybe if their pain gets too much, or, so they have it as for a sense of security and for peace of mind if they need it. So that's the basic definition: a medical practice in which a terminally ill, mentally capable adult with a prognosis of 6 months or less to live can obtain medication prescribed by their doctor to be self-administered to die peacefully if and when they choose. So I've talked about that it's not euthanasia, and it's also not called assisted suicide or physician-assisted suicide. And the reason for that is this is not just the right to die movement saying we don't want to call it suicide. This is some of the prestigious medical associations that also don't want people calling it suicide. Interestingly, the 3 associations on the left have endorsed medical aid in dying, and the 2 on the right have not endorsed it, but they have what they call a neutral position, sometimes also called an engaged neutrality. And that means, for example, American Academy of Family Physicians is watching very closely what's happening in a particular state, their state chapter, because they know if the law is passed in their state, they're going to have to be educated and trained on the law and the safeguards and the qualifications and be knowledgeable about it. So they call that engaged neutrality. But with neutrality, they're not going to be showing up at the State House to protest against it. This is another group, the American College of Legal Medicine, also rejected the term suicide in 1996 when they filed a brief before the US Supreme Court, and then they adopted a formal resolution. Each one of these groups, by the way, has very detailed multi-pages on why they don't call it suicide. It's not just a simple statement. It's very detailed explanation on why. Here's kind of a side-by-side example of some of the things that are talked about as to why it's not suicide. So you can see on the left what medical aid and dying is about, and on the right versus what happens in a suicide situation. Two very different examples of the way to end a life. The laws actually state right in the law that this is medical aid and dying is not these things. And it's important that the law spells it out, because in many states, like Arizona, for example, assisted suicide is illegal. It's a felony. It's on the books. And so they have to be clear in the law saying this is not that. Medical aid and dying is not homicide. It's not suicide. It's not assisted suicide. So the additional requirements would be 2 clinicians have to confirm a patient's qualifications. That would be an attending provider and a consulting provider. They must confirm that there's no coercion or undue influence. They have to put this right in the medical record. By the way, I'm calling it 2 clinicians rather than saying 2 doctors, because I'm talking in general terms about the bill, the way it's written in the states where it's legal. It's legal in 10 states plus Washington, D.C. So I'm saying clinician because one state, for example, like New Mexico, it can be an MD, it can be a DO, but it can also, one of them can be a nurse practitioner or a physician's assistant. So some states are allowing those clinicians. In Arizona, our bill is only MDs and DOs. Patients must be a resident of the state where it's legal. I have a asterisk there because just in 2022, they passed a bill well, there was a lawsuit, and in Oregon now you don't have to be a resident of Oregon. You still have to go to Oregon. You still have to have 2 Oregon clinic doctors as an attending and a consulting provider. You still have to have all those other qualifications of 6-month prognosis of a terminal illness, an adult. You still have to have all those other qualifications, but you don't have to become a resident of Arizona. For example, you don't have to get a driver's license or rent an apartment or register to vote and that type of thing to be a legal resident in Oregon. Other states now are also looking at that since it did pass in Oregon. Additional safeguards, there's oral requests for medical aid and dying, written requests, waiting periods with or without waivers, written statements, and all of this is documented in the medical records. I talk about this generally because different states have different waiting periods and different numbers of requests and written requests. In Arizona, what we're looking at is 1 oral request and a written request for the medication. And there's all details on who has to witness those documents, and a 15-day waiting period that could be waived if the physician determines that the patient doesn't have 15 days to live. Other provisions, wills, contracts, insurance policies, all those things are not affected by a person choosing medical aid and dying. The cause of death is shown as the underlying terminal illness. Some people are really put off by that. It comes up in hearings. They say, well, aren't you asking the medical profession to lie on the death certificate? But this is the way it is with all the other end-of-life options. For example, if you have a stroke and you're disconnected from the ventilator, they don't put disconnection from the ventilator on the death certificate, they put stroke. If you have that palliative sedation that Dr. Fitch was talking about, and you die, they put cancer on your death certificate. They don't put drug-induced coma, so it's very standard practice that the underlying terminal illness is the cause of death. So who can opt out of medical aid and dying? Basically everyone: doctors, nurses, hospice workers, can opt out at any time. Patients can also change their mind at any time. And there's protection of from criminal and civil liabilities if the law is followed. That's also a clause right in the bill. Multiple reasons for choosing medical aid in dying. These add up to more than 100% because people have various reasons for choosing it. This is there's lots of studies based on Oregon because they've had their law since the mid 1990s actually. So there's a lot of statistics that come out of Oregon. You might be surprised that pain is so low on this list. 26% of the people are complaining about pain, probably because we have pretty advanced pain management. And so really the top 3 reasons: loss of autonomy, loss of well-being or quality of life, and loss of dignity are the top 3 reasons for choosing medical aid in dying. So here's the states where it's legal now. I have an asterisk near Montana, next to Montana, because they didn't pass a bill nor have a ballot initiative. They had a case in their state Supreme Court that stated doctors wouldn't be prosecuted for medical aid in dying. You can see that the latest one is New Mexico. Very exciting in 2021 that New Mexico passed. It took them 10 years, and it was a very exciting race to the finish line there. Next states to pass a law. At any given year, there's nearly 20 states that have bills proposed, including Arizona. And many of those states have pro-MAID grassroots organizations like we have in the state of Arizona. And all of them are supported by these 2 national groups, Death with Dignity and Compassionate Choices. Here's some photos from previous years here in Arizona, the Million Geezer March. I just love these photos. If you've ever gone up to Phoenix and testified at the hearings, these were a group of people. This woman here on the jacket on the left-hand side, that's Linda Lopez, who was very active in this movement and a bill sponsor for many years. Here's some other pictures of the protests around in front of the House building and the Senate building there in Phoenix. So they've done some polling in Arizona back in 2015 and 2017. One showing support of Arizonans, 56%. One showing support by Arizona physicians, 53%. So there was a study polling done in January of 2022, and that was 855 registered voters. This Ohio Predictive Insights did the study, which you'll see their studies are quoted a lot of times in Arizona if you follow politics here in the state. 60% of registered voters somewhat or strongly supported medical aid in dying in this January 2022 survey. Only 14% somewhat or strongly opposed, and the balance were neutral or not sure. And what they did was they read a question that was very similar to the definition I just read to you in the beginning of this, and asked, do you support somewhat strongly or oppose somewhat or strongly? And I think the number is so big on neutral or not sure because a lot of people really weren't clear about what the question was about. So if you're not sure what medical aid in dying was, and you got that question in a poll, you might respond not sure. So in Arizona, there's been 8 Senate bills, 12 House bills, and 0 bills that have advanced out of committee. Usually it goes to the Health Committee to die. And this is since 2003. So this group, Arizona End of Life Options, was formed in 2019. There's been other groups over the last 20 years in Arizona under different names. And our group was started by Dr. Fitch and another doctor in Scottsdale who actually taught at U of A. He was 30 years of medical practice in Scottsdale, and he was at U of A years ago. Dr. Ron Fischler. And now our current chair is a Dr. a PhD who helped pass the law in California. And he also he's a snowbird. He also does the mental health evaluations on the patients in Washington State who are, if the doctor questions their mental capacity. So if you're interested in learning more about passing a medical aid in dying law in Arizona, you can join our efforts. We have a monthly newsletter. We have webinars. We have some really good webinars of Tom Fitch speaking. And we have action teams in every legislative district. And of course, we always take donations like every other nonprofit. And we're always looking for groups where we can speak or have tabling. And so that's in a nutshell about medical aid in dying. I wanted to leave some time for questions. So I'm going to stop sharing, and hopefully people have some questions or anything they need clarified.
Thanks so much, Mary. You can just go ahead and jump. Oh, go ahead, Julie. I'm sorry.
Oh, no, it was more like just an observation when you said about 30% of the folks who are approved but don't end up going through with medical aid in dying. I was thinking about how profound choice is, right? And that feeling of powerlessness. And then after I was thinking about that, then you popped up the slide about why do people choose it, and the whole sense of, a loss of autonomy. So it makes perfect sense that just having the option that, like, I get to control if I want to pursue this or not. And so I just, and I had been on another conversation kind of about that thing, about just how profound it is to have the choice about your life when everything else feels like you don't have any control over it. So yeah, thanks.
Exactly. Yeah. But by the way, a lot of discussion was about advanced care planning, which is so important. But I will mention medical aid in dying cannot be put in advanced directives. And if the reason is, people get confused about this, but if you think about it, you have to make the decision about medical aid in dying yourself when you're mentally competent. No one else makes that decision for you. So advanced directives are really only in place when you're no longer making decisions for yourself. You're in a coma, you're in a car accident, you're incapacitated in some way. That's when your loved ones or your trust or whatever looks at the advanced directive and says, what would this person want? So we really support advanced care planning and advanced directives, but keep in mind, medical aid, people say, I'm definitely going to put medical aid in dying in my advanced directive. Can't be done. Okay, because it's only a decision you make when you're mentally competent and still able to make your own decisions. Yeah, Lavina?
I wanted to ask, what is the cost of the meds and who pays for them?
Yeah, good question. That's really, state by state. And in some places, I just, like in California, what's the big insurance company there? Kaiser Permanente is very active in supporting medical aid in dying. So I believe it's covered by Kaiser there. Other states, it's not covered by your health insurance or it's not covered by Medicare, of course. It can, but I think California, has the cost down to something like $650. And the highest I've heard quoted is $900. So it's expensive, but so are other things at end of life. If I used to run a home health business down in Green Valley. If you're paying for 24-hour care, it's really expensive. But there's also groups in every state that has the law. There would be a group that advocates to pass the law, then it's passed, like in New Mexico, End of Life Options New Mexico, then switches to implementation. And they now have funding for people who can't afford the medications. They just apply for this New Mexico end of life options to help them pay for the medication. So it doesn't, in all the states that have the law, I'm very close with the woman who passed the, helped pass the law in Maine. And they have a foundation. So nobody's turned away for not being able to afford the medication. But if you think about it, I wonder if some of those people are in that 30%. They don't get the prescription filled. It's sitting at the pharmacy. They don't want to put out the $900 in case they don't take it.
Right.
And so, they don't have to pay for it until they pick it up. The prescription's sitting there waiting for them. So people are making all these kinds of decisions,
Right. I'm going to start saving.
Yeah. Any other questions? It's a lot of information there. I went pretty fast, but
I think there are some in the chat, maybe.
oh, good.
There is one question about medications. They're saying if pharmacies can create medicine to terminate a life for medical aid in dying, why are there so many difficulties with medications to execute prisoners? And I do know, and you probably can speak to it much better than I can, Mary, but there's been an evolution in terms of the medications that are prescribed for medical aid in dying in those states where it is allowed, and that it was something that they had to learn over time as to what would be effective. And then they also had problems with accessing medications that had been effective in the past and no longer were available and having to switch. So it has been something that's been difficult within this as well.
Yeah. One of the reasons those medications weren't available anymore was because the US was using them for death penalty. And the European manufacturer didn't want to be part of that. So yeah, that's a question I ask myself. I'm against the death penalty, but I don't know why it's so difficult to get that right, because there have been cases where they're claiming cruel and unusual punishment in the process. Yeah. You have to be a resident. Yeah. I've read about people picking up and moving to these states to make this happen. Of course, that's what people do. Brittany Menard was the famous case, the gal in California that moved to Oregon. That's why I think what really pushed this movement. There's been, after California legalized it, they said, we don't want California people having to move to Oregon to do this. So after California passed their law, like 5 states in 5 years passed also. So there's a bit of momentum. Yeah, to set up residency is not that difficult. Like in New Mexico, you just have to do one of the things I mentioned, like a register to vote or get an apartment, or it's also, a little bit looser in New Mexico. They say if you move into the casita owned by your sister-in-law in Santa Fe, the doctor will consider you a resident, so what is death like with medical aid in dying? Basically, you drink one medication to settle your stomach so that you're not going to vomit, and sometime later, maybe a half hour later, you drink the other combination, and you are in a coma in about a minute or so after that. 1 minute, 2 minutes. Then the time of death can be, depending on what your physical situation is, could be a matter of minutes, could be an hour, 2 hours, 3 hours, depending on your physical condition and what your illness is, how it's interfering with your body absorbing those chemicals or those prescriptions. Alan, you want to jump in here and help me with that?
I had communication with a pharmacist that worked for Kaiser in Seattle. And just to let you know, it's you don't go by the pharmacy and pick it up and take it home and say, I'm going to take this. They actually have a whole procedure when the care team comes out to the patient's house. They talk over the procedures. They have a very detailed procedure. They walk the family through it. They walk the family members through it. It's a formal process, and everybody is guided as to what's going to happen. And usually there's family involvement. Some people have parties like the lady you mentioned in California. had a going away party. I mean, it's pretty common for those things to occur. It's a little bit more personal and family involved when people actually make the final move to do that. They encourage doing it that way.
Sure. Someone asks about our governor. Will it make it out of committee this year, given the legislature is still majority Republican? We have a bill. I can't give you a bill number, but it's going through the process. We already know our Democratic governor is in favor of medical aid in dying. Our previous governor was not. He was a Catholic, and so for 8 years we had a governor that would have vetoed the bill if it came across his desk anyway. So we are hoping it might get out of it might be heard in the health committee this year. We're hoping because we do have a couple of proponents in the health committee. So part of it is, having the constituents let their lawmakers know that they're in favor of it. And so we have campaigns for letter writing campaigns, phoning, and we have a lobbyist this year, which is very exciting. He used to be a state legislator, and he was trying to pass the law in Nevada. The two states to watch right now are New York and Massachusetts, are both very close to passing, which would be an enormous boost to the movement. And Nevada came pretty close last year. So we're all rooting for Arizona. You had one more comment, Lavina, and then I think I'm going over. So I think we gotta.
Okay, I just wanted to ask, how do we get notified? Do you have a website, or do you have a newsletter or something for
Yeah,
when
I'll put the
bills do come up?
I'll put the that's our website. If you join, you can get on our mailing list. We have 4,000 people on our mailing list now throughout the state of Arizona, which is very exciting. And we have action alerts, and we have information. We'll have the bill posted on our website when we have a bill number. It'll be a very exciting couple of few weeks once things start moving. We'll know by the middle of February whether it's died in the health committee and won't be switched to the other chamber. So,
Thank you.
well, thank you for your attention. Oh, Phyllis, you had a quick question.
Just very quick. In terms of residency for any state, don't you think it's kind of ridiculous to have to register to vote when you're dying?
Exactly.
I mean, it's just ridiculous.
Well, the other thing that's come up in the lawsuits, and now there's a lawsuit in Vermont, is you don't have to say you're a resident to get a hip replacement in one state. If you live in Arizona, you can go to Nevada and get a hip replacement. It doesn't really, so yeah, the case in Oregon came up because the doctor treated patients on both Washington and Oregon on the border. And he said, I've had this patient for 25 years. And now the doctor in his state across the border in Washington has to be his doctor now that he wants medical aid in dying. It happened to be two states where it's legal in both states, but he won the case. And it was sort of a commerce, interstate commerce.
Why
idea.
is residency such an important thing in this?
They just had to come up with a list of qualifications and safeguards back in the 90s when they started this. And ever since then, they've always used the Oregon model. And very little has really changed from that original Oregon model because it's time tested. It's never been brought up to the Supreme Court, and it's so well written. And residency was part of that. Now that Oregon has been able to get rid of that residency requirement, other states are looking at possibly amending because it's amending their laws also. Yeah.
David, do you want me to go?
That would be great. Why'd you take them?
Mary, thank you to you and Tom so much for sharing. I learned a ton tonight. Thank you everyone for staying with us through this hour and a half. I would like to just invite you, if you'd like to continue joining us every month. We do this. It's the third Thursday Normally an hour and a half, starting at 6 p.m. next month will be Xander Masser, who really learned about his dad through his dad. His dad was a photographer who died when Xander was in his teens. And the story that he will share with us is all about his journey of rediscovering his dad through his dad's photos. And then, as I mentioned in the beginning, we'll have many diverse topics. March will be about ethical wills. I believe April might be a game night. We're not sure yet. It will be April or June. So we have a lot of cool things coming up. We appreciate you being with us. We appreciate those of you who have chosen to donate to help underwrite the cost of us making this free and open to the community. And hope you have a lovely evening and that we see you again next month. Good night, everybody.